All right, Chapter 5, Variations in Consciousness. So as I've mentioned before in the prior lectures so far this semester, one of the things we try to do at the beginning of each lesson is to operationally define our terms, basically to make sure that we're all clear on what exactly we're talking about. Well, in this case, that becomes a fairly difficult thing to do. If you take a second and you think about it, other than just trying to provide perhaps some synonyms like awareness or sentience, consciousness is a fairly difficult thing to define. It's a fairly difficult thing to put your finger on exactly what is this thing that it is to be like me. In fact, that is actually a definition that sometimes people propose, is the experience of being like something. So if you think about it in those terms, there's no real way to conceptualize the likeness of being a rock or a tree. And to whatever degree we try to do that, we anthropomorphize the experience. We make it human-like. On the other hand, you can perhaps imagine, without doing so in terms of what it means to be a person, you can imagine perhaps what it's like to be a dog, or to be an elephant, or to be a dolphin, to be a monkey. All animals which we suppose have some semblance of consciousness. But moving beyond that, it becomes a very difficult thing to define. We tend to talk about it in largely in terms of synonyms, like I said before: sentience, awareness. We talk about being aware of, conscious of our surroundings, or conscious in terms of being aware of what's going on internally, being able to monitor our thoughts or monitor our feelings. We talk about it in terms of subjectivity as opposed to objectivity. That we have some internal awareness, again, awareness. We conventionally, kind of culturally, we talk about consciousness often as a synonym for wakefulness, which is actually problematic, because we're going to talk about sleep later in this lecture. But if you think about it, if you consider consciousness to be some degree of awareness of external events and internal events, so I can be aware of what is going on around me, I can be aware of my own thoughts, my own emotional responses, etc., the internal sense of what it is to be me, then it's not any stretch at all to recognize that even while asleep, we are conscious. Certainly during a dream, right? We're clearly conscious during a dream. There's clear awareness. Now, it's awareness that is, for lack of a better term, hallucinatory in its nature, right? We're experiencing something that appears to be real to some degree or another. We're experiencing things that are not objectively there in the world, that nobody else can experience. We're locked in our own experience. That is the dream. And I mean, a hallucination is essentially something that we perceive that doesn't have a sensory component, right? Where our brain is telling, if you have a visual hallucination of a person standing there and nobody else can see that person, well, you have the perception of that person without the sensory input, right? Your eyes aren't picking up light being reflected off an actual individual in the case of a visual hallucination of a person, but your brain instead is giving rise to that experience. So you have a perception of it, but without the sensation of it. And that is exactly what a dream is, right? You're having a visual experience that doesn't correspond to anything in reality that doesn't correspond to anything that anybody else can detect. So in that sense, we certainly have some degree of consciousness during sleep, but even on a more mundane level, we have a degree of consciousness during sleep, because if you're asleep and somebody walks in the room and says your name, the likelihood is, if they say it loudly enough, you're going to wake up. Even if you're in deep sleep, we can come over and shake you awake or poke you with a pin or something to wake you up. If you were truly without consciousness during sleep, you wouldn't respond, right? There would be nothing outwardly directed. There would be no awareness outwardly directed in your psyche, so to speak, to respond to that stimulus to awaken you, right? So talking about wakefulness as consciousness is imprecise and is not actually a very practical way of talking about it, because even during sleep, we are conscious. At a lesser level, certainly, but conscious. We also talk about consciousness in terms of what we call an executive control system, which is problem solving, anticipation of consequences, all that kind of the higher cognitive functioning that we associate with being human, that we associate with personhood. Which would be another way of discussing consciousness, and that becomes a major issue when you have arguments around things having to do with the value of being a person. Things like abortion and euthanasia and things like this, which are all, when you have those arguments, when you have arguments centered around personhood, centered around a person, a human person having value, they generally kind of coalesce around this question of consciousness and the potential for consciousness. I'm saying all this to say we have a very difficult time objectively defining our terms when we talk about consciousness, despite the fact that it's something that we all possess. If I say consciousness, you have some general idea of what I'm talking about, even if we haven't gone through this kind of dissemination of all the different kind of nuances of meaning that we have for the term consciousness. A very, very unique state, a very unique circumstance for us that universally experienced, nearly universally recognized among people, but very, very, very difficult thing to define, very difficult thing to kind of pin down. Sam Harris, who's a fairly well-known consciousness researcher, he's a neuroscientist in California, I think it's with UCLA, has a podcast, absolutely highly recommended, very, very interesting guy, very bright guy. Most of what he talks on his podcast frequently about politics, with an interesting perspective on that. He is a fairly adamant atheist and makes very forceful arguments against religion generally. That's gotten him in trouble occasionally, particularly for his opinions about Islam, although his rejection of religion isn't just a rejection of Islam, it's a rejection of all theistic philosophies. But the place where his podcast is most valuable is around consciousness, because that really is his true area of expertise. And this slide is a quote directly from him. "The term consciousness is notoriously difficult to define. Consequently, many a debate about its character has been waged without the participants finding even a common topic as common ground. By consciousness, I simply mean sentience in the most unadorned sense. To use the philosopher Thomas Nagel's construction, a creature is conscious if there is something that it is like to be this creature. An event consciously perceived if there is something that it is like to perceive it. Whatever else consciousness may or may not be in physical terms, the difference between it and unconsciousness is first and foremost a matter of subjective experience. Either the lights are on or they are not. And the thing I find interesting is this statement is coming from one of the most knowledgeable people, not just philosophically, but physiologically, the most knowledgeable people on the planet about consciousness. And even he is essentially is having a difficult time really pinning down to what exactly does he mean by it. And he actually points out one of the thing that I'll just mention very quickly that I think is very interesting. There's an argument that you see sometimes proposed in psychology and philosophy that consciousness might not actually exist. Certainly, it's not in the scientific sense. It's not something that we can objectively measure or observe other than in ourselves. And so you get some people saying, well, it might be an illusion. And Harris, I think, has a very effective response to this, and pointing out that the only thing in existence that isn't possibly an illusion is consciousness itself. He argues that you can't prove the existence of anything else completely and totally. Everything that you experience could hypothetically be an illusion, but consciousness cannot be. The awareness of, in his words, the awareness of what it is like to be something, or what it is like to be aware, to be awake, to be a human, to experience the perceptions that you experience, can't be an illusion. That the things that you believe that you perceive, as in the case of a hallucination, can be an illusion, or in cases of actual illusions, can be an illusion. But the experience of consciousness, Harris argues, and I think convincingly, is the one thing in the universe that cannot be illusory. So, this brings us to the question of what actually causes consciousness. And the truth of the matter is we really do not have any idea. Well, that's not true. It's not fair to say we have no idea. We do not really know. We know some things, some activity in various parts of the brain that is correlated with consciousness. Remember, we talked earlier in this semester about the distinction between causality and correlation, right? You can have two things that are related to one another, and they can be very, very, very strongly related to one another, but that doesn't necessarily mean that one causes another. I'll talk about why this is a big deal here in just a second. The one thing that we do know is that consciousness is correlated with a high degree of interconnectedness between parts of the brain. And the way we know this is that we can look at activity in the brain during different levels of consciousness for a person, in and out of sleep, say, for example, or under differing levels of sedation. And what we see is that the person becomes conscious in the sense that they can respond to us and communicate with us as a certain degree of electrical activity occurs between different structures in the brain. Now, it almost inevitably involves the prefrontal cortex, the part of the brain that is responsible for what we call executive functioning, which is what I was referring to earlier in terms of problem solving, anticipation of consequences, logic, these kinds of things, right? So high level of interconnectedness between structures in the brain, prefrontal cortex certainly is involved. And then there is also what they call the posterior hot zone, which is essentially parts of the parietal, temporal, and occipital lobes. And we know that these parts of the parietal, temporal, and occipital lobes are involved in the experience of sensory information, and really, and as it relates to consciousness, because what we find is that when there are lesions in the posterior hot zone, people can lose conscious experience of extraordinary things. A lesion in a certain part of the occipital area of the posterior hot zone, and the person no longer recognizes faces. In a different part of the posterior hot zone, and they can no longer perceive motion, not even in their dreams. They can't even dream about motion, not emotion, but movement, motion anymore. So, and if that's hard for you to imagine, join the club. That's a hard thing for me to imagine also, but you can rob somebody of that conscious experience by damaging a particular part of that part of the brain. So we know that there's and if you think about what I'm saying, okay, well, so we have frontal lobe activity, prefrontal cortex, parietal lobe activity, temporal lobe activity, occipital lobe activity. So obviously cortex has to be involved. And just activity in the sensory cortex is insufficient. That's not in the parietal, like the front of the parietal lobe, that primary sensory cortex up there, not enough. So I mentioned before correlation, not causation. We know that activity in these different parts of the brain and communication between these different parts of the brain is correlated with states that we recognize as consciousness, right? And we're making an assumption that probably what is going on in these different parts of the brain, communication between these different parts of the brain, probably is causing consciousness. But you actually get some really interesting arguments, say, for example, from physicists. There are some physicists who have gotten involved with the study of consciousness. Most famously, Roger Penrose, brilliant guy, mathematician and physicist at Oxford University in England, and he was Stephen Hawking. You may remember or know who Stephen Hawking is. He's the guy who was confined to his wheelchair by Lou Gehrig's disease and talked through a thing that automated his voice. He sounded like a robot, and he was depicted in cartoons, and he died not too long ago. At the time he was alive, the most famous living physicist. Well, Roger Penrose was his research partner, and Penrose, as a physicist and mathematician, got interested in the study of consciousness, and he and some other physicists make some interesting arguments. He makes arguments about the involvement of some of the internal structure of neurons called microtubules being involved in the experience of, so he argues that consciousness is arising not from interactions between neurons, but from within neurons. Interesting. Other physicists are making the argument that consciousness may in fact be a force in the sense that gravity, say, is a force, and that our brains essentially act as tuners, for lack of a better way of describing it, that we experience consciousness which exists independently of us via our brains. Now, I'll be honest with you, I have limited understanding of this. When you get talking to physicists, they can very quickly lose you because they speak in kind of their own language, and they're basing their suppositions on knowledge that most of us do not share, especially when you start talking in terms of quantum physics, which is where the Penrose stuff really is based. Actually, it's based in the space between quantum physics and relativity, Einsteinian physics, which is mind-blowing in and of itself. At any rate, the reason I'm sharing all this with you is I want you to recognize just how baffling and challenging looking at and trying to understand consciousness really becomes. It is not as simple as it initially appears. And it truly is. If you are in the fields of biology, chemistry, physics, or psychology, neuroscience in general, and you want to really get involved in the cutting edge stuff, studying consciousness is truly cutting edge. It's hopefully where we're going to be making some pretty big breakthroughs in the relatively near future, fingers crossed. Just a picture of what I'm talking about when I'm talking about the parietal lobe. Prefrontal cortex, which is actually not labeled on there, but the prefrontal cortex and the parietal and the posterior hot zone involving the parietal lobe, occipital lobe, and temporal lobe, sections of those necessary for the experience of consciousness. Another interesting thing to talk about in terms of consciousness. This comes from a philosopher in Australia who is one of the more famous, more well-known consciousness theoreticians. And this is what he calls the hard problem of consciousness. He says, it's undeniable that some organisms are subjects to experience, but the question of how it is that these systems are subjects of experience is perplexing. Why is it that when our cognitive systems engage in visual and auditory information processing, we have visual or auditory experience, the quality of deep blue, the sensation of mental sea? How can we explain why there is something it is like to entertain a mental image or to experience an emotion? It's widely agreed that experience arises from a physical basis, but we have no good explanation of why and how it so arises. Why should physical processing give rise to a rich inner life at all? It seems objectively unreasonable that it should, and yet it does. So what he's saying here is you could hypothesize, you could imagine perhaps that you could have processing, visual processing, auditory processing, in the sense of sensation and response, right? So you see something and you respond to it. You hear something and you respond to it, without the additional layer of an internal experience of that visual sensation. Thinking about it in a slightly different way, you can imagine, say you imagine an ant, and an ant has sensory experience, right? You can, if you reach out and you try to touch the ant, it scampers away, right? It's sensing you, presumably perceiving you, and like perceiving, of course, meaning the brain is processing that sensory input. But it's also fairly easy to think of an ant as just information processing with no conscious awareness. We don't think of ants sitting in their little ant holes and contemplating the meaning of the universe or the futility of existence, right? We don't see them awakening in the middle of the night, tortured by the brief time that is their life, their lives. So this philosopher, his name is David Chalmers, by the way. Chalmers is making the argument that sensory sensation and perception, the processing of what's going on around the world so that we can interact with the world, doesn't necessarily require that we have conscious experience of it. We could basically just be robots processing information and responding to it. Why, he's asking, why do we actually have a conscious experience of things? And he actually makes the argument that it's not. You can argue that it isn't even necessarily an asset to survival, and certainly one of the things and evidence of that is the reason that people suicide, the reason why people end their lives is because of consciousness. Consciousness is the source, certainly of pleasure, but it's also the source of suffering. If you are not conscious, and you reach out and you touch something that is hot and it burns your hand. If you're not conscious, you can imagine you burn the hand and you withdraw from that sensation of pain, but if you're not conscious, you have no experience of the pain. So you can imagine this, hard to wrap your mind around, but you can imagine a circumstance in which you have these sensory instruments and you have the perceptual processing of that sensory information, but without the awareness associated with it. And he's arguing that essentially it doesn't seem to be necessary. Think of it in an evolutionary sense. What advantage do we gain from consciousness? In fact, it might not be an advantage, it might be a disadvantage. So the hard problem, to make it a little simpler here for you, the hard problem is, Chalmers is arguing, the hard problem of consciousness isn't how does it come about, what are the mechanisms by which it comes about. That's hard enough, but the really hard problem is why? Why is it necessary to be conscious? What is the purpose of it? And again, I'm presenting this to you, one, because you need to be aware that these questions are being asked, but two, just because to give you a sense of just how complicated this whole field is. By the way, this is David Chalmers. Not what you would expect necessarily from one of the great minds on the planet. He frankly looks disturbingly like a character that you may recognize if you like movies from, what was it, the late 80s or early 90s. Oh gosh, Wayne's World. Looks remarkably like, I don't remember which character this was, but looks remarkably like one of the characters from that movie. Ha, I think that's funny. So all of these interesting kind of philosophical and mind-bending sort of observations about consciousness aside, one thing that we can say indubitably is that consciousness is certainly not all or none, right? There are degrees of consciousness, no doubt. There's full alertness. There's the experience of being in the zone, which is a very unusual, fairly unique state of consciousness, perhaps not unlike hypnosis, which is, by the way, very real. But being in the zone is a state in which we lose. You have athletes and musicians and artists describing this most frequently as a state in which they are immersed in the moment. They lose a sense of self. Time often becomes a kind of a non-issue. They're not experiencing existence in terms of the sequencing and concern about the past, worry about the future, these kinds of things. They dissipate. Often they talk about when you're in the zone, that language processing seems suspended, that you're not thinking in words, you're not planning, you are just being. And if you've played sports at a sufficiently high level, or you perform music or another art, dance, that kind of thing at a sufficiently high level, you may have experienced this. It's a very, very difficult thing to put into words, but it is clearly, if you have experienced it, you'll recognize it is not the same thing as just being awake and alert. Relaxed wakefulness, I'm not going to go through every single one of these, but relaxed wakefulness is actually a term that we use for that kind of transition period as you begin to move towards sleep. You're laying there and you're transitioning towards sleep. We're going to talk about that in a few minutes. Seizure activity represents varying levels of consciousness. In some cases where the person has awareness of what's going on around them, and in some cases where they do not. Dementia, Alzheimer's, and similar states in which you progressively find yourself diminished neurocognitively, just broadly, particularly in the area of attention and concentration, access to short-term memory in particular. Long-term memory is sometimes often left largely intact. Planning of executive functioning, right? Planning, anticipation of consequences, this sort of thing. And again, there's very, very mild states of dementia all the way down to such severe dementia that the person is essentially no longer responsive and appears questionably conscious, right? Delirium, hyperactive and hypoactive delirium. Delirium is a state that you usually end up talking about in medical settings. Delirium can occur as the result of a severe illness. It can occur as a person is coming out of anesthesia, and it's essentially when they're not reactive to the environment around them in a way that would suggest that they are fully conscious. So hyperactive delirium is they're very, very agitated. They might be fighting you. I have a lot of patients who my primary job as a clinician in a medical clinic for the VA, for Veterans Affairs, most of my patients there are combat veterans, and it's not an infrequent thing. We actually have to warn the surgeons when you put these guys under anesthesia for a surgery and you start pulling them up out of it. It's not unusual for them to have a hyperactive delirium. They'll actually have a flashback. They'll feel like they're back in combat, and we don't really know why that is. At least as far as I'm aware, we don't know why that is. So hyperactive delirium is that very, very agitated, sometimes combative sort of a state. They don't really know where they are. They don't really know what's going on. Sometimes they might be having a flashback or a hallucination. Hypoactive is the reverse of that, or the converse of that. The person looks like they're awake. Their eyes are open, but there's nobody home. You can look at them, you can talk to them. They seem to be looking at you, but they're not responding to you. You can perhaps elicit some response to them by pain, by pinching them or poking them with a needle or something. You can cause some degree of response, but they're not really responding to you in any reliable way. Intoxication. I'm not going to spend much time talking about this in the lecture, simply because we've got too many other things to cover. And the book does actually go into a little bit about states of intoxication or being high on drugs. We're going to talk at length about sleep in a little bit. I already mentioned the state of hypnosis, which is real. I think I probably will post a link to the crash course video for hypnosis. They do a good job talking a little bit about the state of hypnosis and kind of dispelling some of the myths around it and so on and so forth. I want to make sure I mention sleep paralysis. Sleep paralysis, mostly because it's actually really not particularly unusual. I want to say it's something like 20% of the population, I think is what it is. Approximately 20% of the population experiences this. This is awakening from sleep into a state of paralysis. So you wake up out of sleep and you cannot move. Generally speaking, the people who experience this will also tell you that they have the perception of somebody being in the room with them. They'll wake up and sometimes they actually can see a figure in the room with them. Sometimes they'll report a sense of sometimes that figure is described as being actually on top of them and pressing down on them. Sometimes they'll talk about having a pressure on their chest, and it can last from just moments on up for several minutes, and is apparently terrifying. I make sure that I mention this because it is actually a unique state of consciousness. and it is harmless. There does not appear to be anything negative associated with it. It's not a sign that you have something wrong with your brain. It doesn't appear to be associated with any sort of other dysfunction that we can identify. What it does appear to be is, we're going to talk about this when we talk about sleep. When you go into deep sleep and you transition from deep delta wave sleep, which again we're going to talk about, into REM sleep, dream sleep. One of the things that happens during dream sleep is that your brain creates a state of what we call essential paralysis. Your brain paralyzes your body, because if it doesn't, what happens when you dream is you act out your dreams. And that actually is a problem. If you're acting out your dreams, there is a correlation between people not entering that state of essential paralysis during REM sleep, during dream sleep, and instead acting out their dreams. There's a state of there's some correlation between that and having later neurodegenerative problems, things like dementia and that sort of things. It's called REM sleep behavior disorder when you're acting out your dreams. It's actually potentially very dangerous. People die because they get up and they move around. In some cases doing really complicated things like going out and getting in their car and trying to drive. So it can be extraordinarily dangerous not to have this essential paralysis. So the reason I was talking about the essential paralysis that is part of REM sleep or dream sleep in the first place was to say sleep paralysis is you're in REM sleep, you're in dream sleep, your body is paralyzed, and for some reason you get things you get the brain processes just a little bit out of sync, and you wake up while your brain still has your body in this state of paralysis, so you don't act out and get hurt while you're dreaming. And then there does appear to be some evidence that sometimes you wake up and the part of your brain that is active during dreaming, which is creating all of these hallucinations, because that's what's happening when you're asleep, right? And you're dreaming, you're hallucinating. You're seeing things and hearing things that aren't actually there. Well, you can come up, you're awake, you are conscious, you see what's going on around you, but you're also, in some cases, experiencing parts of a dream. So you can see things that aren't there, say, or hear things that aren't there, and are unable to move. Understandably, potentially very, very frightening, very, very frightening sort of an experience. I'm not going to speak much about deep meditation, other than to make the note that it can achieve. It can end up being very similar to a state of deep hypnosis. Very, very deep meditation is very similar to hypnotizing yourself. And then we move into the range of true unconsciousness, deep coma, which we're going to talk about in just a minute, and sedation under deep anesthesia. If you've ever had a surgery where you were really put under, really actually had fairly deep anesthesia, it's a very strange experience. If you go to sleep, you'll often awaken with some sense of how much time has passed. Sometimes you go to sleep and you go into really, really deep sleep and you wake up and you're not sure how much time has passed, but you're relatively certain it was a fairly extended period of time. Deep anesthesia is kind of like being knocked unconscious. Unfortunately, I've had both experiences, and in both cases, you awaken. In the case of being knocked unconscious, the couple times that I've had that happen, I awoken, and this is not unusual, I awoke not only not knowing that I had been knocked out, but not knowing how long it had been knocked out. Right? So I had amnesia for the actual event that rendered me unconscious, and had no idea how long I had been out. It actually was a fairly brief period of time, but it was just missing time. And that's the same thing that happens under some kinds of anesthesia, is that they'll come in and they'll either deliver it through a respirator, or they'll give you a shot. And sometimes they'll say, you see it in the movies, like, okay, I want you to count backwards from 10, and you don't make it to 1. Sometimes you don't even make it to 8. But one of the times I can tell you that I had anesthesia, and this is not an unusual thing either. When I came, I remember sitting there in pre-op. I don't remember them coming in and saying, a vague memory of them coming in and saying, okay, we're going to go ahead and they didn't say put you under, but we're going to put you under now. And then I was awake. I was there, and then I was not there, and then I was there again, with no sense at all. I mean, it could have been a year that had gone by. I wouldn't have had any idea. It was just absolute absence of time. It's a very strange experience if you have not had it. If you haven't had it, you probably will, because most people at some point undergo some surgery that involves anesthesia. But it is a profoundly different experience. The absolute absence of consciousness is a very different experience from just going to sleep, dreaming, getting really, really drunk and passing out. These are very, very different experiences than from true unconsciousness. So kind of moving along those lines, how do we determine if a person is conscious, or to the extent to which a person is conscious? If we're talking in terms of varying degrees or varying levels of awareness, you would think that we would have some fairly technical and complicated way that we measure this. In fact, it's pretty rudimentary. It's pretty basic. It's the Glasgow coma scale that is these 3 categories under which you score levels of responsive behavior: eye-opening behavior, verbal behavior, and motor behavior. That's what we use. You go into an emergency room and you are blitzed out of your mind. You drank way, way, way too much, enough that your friends got worried about you and took you to the emergency room, and this is what they use. You have a head injury. You're in a car accident, have a head injury, and you come in, and this is what they use. This is how they detail the degree of which the degree of consciousness that they're seeing in you. And what they're detailing, they categorize according to 5 different levels: alertness, lethargy, which they also call somnolence, obtundation, stupor or semicoma, and full coma. Alertness, we don't really have to go into too much, because hopefully that's what you are right now. You're fully responsive, you're capable of interacting with your environment, you're aware of what's going on both externally and internally, and you are capable of sustaining some degree of focus. Lethargy, the second, we're going from full alertness down the degrees of consciousness to full coma. So the second one, moving down, lethargy or somnolence, you're not fully alert, your attention can wander, you're not as physically active as you would normally be. You may demonstrate some circumstantiality or some tangentiality. Circumstantiality is frankly what I am. I'll be talking, and I'll say, oh well, and I'll go off on this, well, what we would normally call a tangent. I'll go off and I'll talk about something, and then eventually, it may take a long, long time, but eventually I almost inevitably end up coming back to the subject at hand. That's circumstantial. Wander off on some other topic, but I bring myself back. Tangential, which is a little worse, is when you go off on the tangent and you don't come back. You have to be redirected to get you talking about what you're supposed to be talking about. Instead, you go off wandering off, and this thing makes you think of this thing, which makes you think of this thing, and you just keep going further and further and further away. So verbally tangential or circumstantial, and then your eyes are open but dull and without animation. And if you can think about it, this is kind of what this is not just intoxication, but this is what somebody looks like when they're noticeably drunk, not fully alert, difficulty sustaining attention, not moving around as much, kind of, you can still understand what they're talking about. They can still communicate with you, but they're not real focused. And then they get the drunk look in their face. Their faces are with less animation. Their eyes look kind of dull. They're not necessarily sleepy, but they're just not as responsive. They're not as active. So you can get this. You can get this from if you get your bell rung pretty hard, you get hit on the head, and you're not fully knocked out, but you're a little loopy. You can get like this. You can get like this, like I said, from using drugs or alcohol. You can get like this if you have a very, very bad fever. So you can picture these things, these states, which you probably have experienced or you've seen somebody around you experiencing, to picture what lethargy or somnolence looks like. Obtundation is the next level down, and this is a person who, the way I think about this is a person who is really, really, really intoxicated, who is awake but in the throes of a bad fever, or somebody who got hit on the head really, really hard, so hard that they don't even really necessarily know where they are. Right? So if you can kind of picture that's what we're talking about here. So they're hard to get them to interact with you and cooperate with you. They're awake. They're not asleep, but they're minimally responsive. So they're kind of laying back in the chair. Their eyes may be closed. If you say to them, hey, wake up, look at me, you can get them to kind of open their eyes and maybe orient towards you, but it's hard to get them to actually interact with you. As soon as you stop snapping your fingers and yelling at them and waving your hands, they kind of drift back off again. They're kind of, their eyes might be open even, but they're just not attending to what's going on around them. We talked about delirium before. So it might be kind of a hypoactive delirium, or it might be a hyperactive delirium, or what we also call an acute confusional state, where they're agitated, but their movements aren't real organized. That they're just pushing against you, and again, you can picture somebody who's very, very intoxicated. Not really. They're in the state of obtundation. Generally, when you talk about somebody as obtunded, they're looking like they're almost asleep, or they're so intoxicated they're almost asleep. Difficult to arouse, difficult to get them to respond. You got to work really, really hard to get them to interact with you, and even when they do, they seem confused and uncertain. And obtundation, transitions, moving down the scale still into stupor, which we also call semicoma. This is a situation where the person, they look as if they're asleep. If you really, shake them or poke them or yell at them, you can get an acknowledgement that you are stimulating them, right? So they'll groan, they'll mumble, they'll protest. You come up and Mr. Smith, like in an emergency room. Somebody comes in and they're in this state. You want them awake, because if they're not awake, you can't find out what happened to them, right? You need to be able to interview them. And so you're the person who's in a stupor. You're shaking them and yelling at them, and perhaps even inflicting mild pain, a pinch or a poke or something like that. And all you're getting from them is just, they might try to kind of pull away from you, and it's like somebody who's trying to stay asleep. Is really what it looks like. They're not able to give you any information. They don't even necessarily appear confused, because they're not alert enough to be confused, right? So this is the person who, maybe a different way of thinking about it is, they're essentially as if they want to be asleep and you're the thing keeping them awake, right? Stimulation is the thing keeping them awake, and they just want to move away from that and go to sleep, right? So that's stupor or semicoma. And then coma is what you picture from television shows and movies and such like that. Unresponsive, eyes closed. They're not responding to external stimuli. You can come in, you can yell their name, you can give them a little shake, those kinds of things. You can poke them, and you're not going to get a behavioral response. You can't even call them confused. They are not responding to you. In light coma, you can test some of the reflexes, and they're still intact. The nervous system is still functioning to that degree. In deep coma, even the reflexes have dissipated and they're not responsive. Okay, at this point, I'm going to transition, and we're going to spend, I think, the rest of the time talking about sleep, simply because it is an underappreciated topic. And it is the daily variation from your kind of general state of wakefulness, right? So as I kind of spoke briefly about a few minutes ago, it isn't a passive state of unconsciousness. It's not a suspension or it's not just a suspension of normal body activity. And of course it is. You're not moving around as much as you normally are. But there's a whole lot more to it than that. If we're going to, again, operationally define it, we talk about sleep in terms of it obviously naturally occurring, reversible, so you go in and out of sleep, periodic and reoccurring. It involves both the mind and the body. And when we talk about the mind, obviously it involves the brain, but the brain is part of the body. When I'm talking about it involving the mind, what I'm referring to is that dissipation of full consciousness that is our experience of sleep onset, right? You know, we appear to be shutting down, you know, going into hibernation like a computer or something. That temporary reduction or suspension of consciousness, we become less responsive to the environment, and muscle tone diminishes, right? You know, the body really does relax. So when we're talking about sleep, that is part of what we're talking about. When I say part of what we're talking about, what I mean is that when you almost need to have some sort of functional scan in order really to determine whether you're fully asleep. And most of the time what we use is an electroencephalogram, an EEG. We'll talk about that in a little bit. We'll talk about the brain waves and such associated with different kinds of sleep. But one thing, part of the reason I'm talking to you about this is I want to impress on you just how absolutely vital healthy sleep really is. I think I've said to you, I know I've said to you before, that I work in a medical setting, and I would say easily half of what I do is treating things that we think of and are psychological conditions, depression, anxiety, that sort of thing. Even in some cases PTSD, primarily by fixing diet, activity level, exercise, and sleep. The reality is, if somebody comes in and you get them to the point that they're sleeping 8 hours a night, exercising vigorously every day, and eating a healthy diet, and the odds are that whatever psychological distress they're experiencing, especially in the cases of depression and anxiety, is going to improve dramatically, often as much as it would from counseling, psychotherapy, or medicine. It's that big of a deal. And sleep, if I was going to pick one, that'd be tough. But boy, it'd be tempting to pick sleep because it just makes such a profound difference across your life. If you deprive somebody of sleep, especially over time, you create all sorts of health problems. The one that I'm most alarmed by is that if you're chronically sleeping less than 6 hours per night, the rate of heart disease, heart attack specifically, not just heart disease, heart attack and stroke go up 4-fold. Let me clarify that. 4-fold. That means you're not 2 times as likely to have a heart attack or a stroke. You're not 3 times, you're 4 times as likely. That's an astronomical change. And it happens because you sleep less than 6 hours a night on an ongoing basis. Big big deal. Okay, sorry about that. I got a phone call that interrupted here, and I can't really remember exactly where I left off. I was complaining about all the bad things that happen when you're sleep deprived, all the health problems, and they are just myriad. You know, it's not just stuff like, oh, you can have a heart attack and a stroke, so much more likely to have a heart attack and a stroke. It's also things like you gain weight. You're much more likely to be overweight if you're not sleeping well. Blood sugar stability, which is related to gaining weight, undesired weight gain. Blood sugar stability diminishes, insulin resistance increases. You get all sorts of health problems that result from all sorts of hormonal problems with your health. Testosterone levels, if you're male, testosterone levels diminish. Cortisol levels, which is like the stress-related hormone. I'm oversimplifying it, but your stress hormone increases. Just tremendously problematic. Okay, hopefully that's the last one. Got interrupted again. But what I was saying was that okay, so you got all these hormone problems and all these health problems that arise when you're sleep deprived. But the converse is also true. If you're sleeping well, you get all sorts of positive benefits. One of the ways of talking about it is sleep deprivation is catabolic. Good, healthy, extended, restful, restorative sleep is anabolic. Catabolic and anabolic basically meaning catabolic is the process of breaking molecules down to be used for energy. Anabolic is building them back up. Anabolic steroids, we talk about anabolic steroids because they're helping the body build itself back up, helping combine proteins and produce muscle and so on and so forth. Catabolism, exercise is catabolic. Exercise is you're breaking things down in the body to use as energy. You're breaking down muscle when you're exercising. And in order for exercise to be beneficial, you need the post-exercise anabolic period, which is the result of healthy food intake and good restoration, good sleep, right? If you are stress is catabolic. Stress causes you to enter a hormonal state where you're inclined to break things down to use them as energy, or to store things in a way that they're easily available for energy, store them as fat. Whereas sleep reverses that process to a fairly significant degree. Sleep is anabolic. Sleep is a good, healthy state to be in. I'll talk about amounts here in just a second. As important as sleep is, and as important as we know about how valuable it is and how detrimental it is if you're not getting enough, there's a lot we really don't know about it. One of the remarkable things is that we don't really know, we can't pinpoint, even with an EEG, we can't go like, and now you're asleep. If you're creepy enough that you want to stand and watch somebody fall asleep, there really isn't a point. In fact, what you might find happening is, you're watching them and they're getting drowsy, and now their eyes are closed, now they're not moving as much, and they appear even to be breathing deeply enough that you're like, oh, you're starting to snore a little bit. Oh, they're asleep. And they go, no, I wasn't. We really don't know when it starts. We don't know the exact physiological mechanism that starts it and stops it. We know some things that are correlated with it. We know some things that are related to it, but we don't really know what the exact mechanism is that begins and ends the sleep. We have some ideas about why we dream. There certainly is an emotional component to it. There's definitely a memory component to it, but we really don't definitively know why we dream. We don't know exactly what it is in terms of selection that caused sleep to evolve. There are certainly some evolutionary assets to sleep. Avoidance of predation, say, that if you're not moving around as much at night, you're a little less likely to get eaten by large predators who tend to hunt their meat at night. On the other hand, if you go to sleep at night, you are vulnerable to predation. So we really, there's, for something that is so vital and so much part of our day, it's kind of like consciousness. We really don't know why. There's a lot we don't know about why we do it and how we do it. What we can talk about are the stages of sleep, and we'll talk about it in terms of, well, wakefulness. Sorry, we'll talk about it in terms of the EEG patterns that correspond to each of these states. Okay, so we talk about wakefulness in terms of beta waves, which frankly looks like a fast up and down scribble across a page. The waves do not appear to have any pattern. The brain waves don't appear to have any pattern. They tend to be fast and erratic. Relaxed wakefulness. Remember, I was talking about that before. This is as you're transitioning into sleep, and we call these alpha waves. Alpha waves are the brain waves that you show when you are very mellow, when you are very relaxed, when you're very, very calm. We call these alpha waves. And what you get and I'm going to show you a picture of this in just a second on the next slide. I think it's the next slide. But alpha waves are basically what you see as the beta waves begin to slow down and spread out just a little bit. Stage 1 sleep, again, there's no point at which you can go, oh, okay, now there's stage 1 sleep. You just see, as you go into sleep, you see the beta waves slow down a little bit and become alpha waves, and then as the number of waves during a certain period of time occurs less frequently, you enter into stage 1 sleep. We call these waves sufficiently spread out, theta waves. As you move into slightly deeper sleep, what we call stage 2 sleep, it isn't so much that the waves diminish in frequency. You still are in theta wave sleep in stage 2 sleep, but what we start to see, the thing that distinguishes stage 2 sleep, are periods of activity from the brain that are clearly intended to preserve the sleep. Right? So if you're in stage 1 sleep and somebody comes in and says your name or something, you wake up. If you're in stage 2 sleep and somebody comes in and says your name or shakes you or something, you get this brain activity, things that we call spindles and K complexes, that appears to be your brain trying to prevent you from coming up out of your sleep. It's trying to protect your sleep and preserve it. That is the point at which you're transitioning in to what we now call deep sleep. We used to call it stage 3 sleep and stage 4 sleep. Now we just call it deep sleep. That's characterized by very slow wave EEG activity, what we call delta waves. And then after you get into deep sleep for certain periods of time, and we'll talk about how that looks different, because you go through these stages of sleep, depending on how long you sleep, 3 or 4 times over the course of, say you sleep 8 hours, 3 or 4 times over the course of 8 hours, you'll transition from stage 1 sleep into stage 2, into deep sleep, into REM sleep or dream sleep, and then back up into really shallow sleep, theta or stage 1 sleep, and then back down. We'll talk about how long you spend in each respective period here in a little bit. But you do transition through these stage 1, stage 2, deep and REM sleep 3 or 4 times over the course of a night. You get into deep sleep with the delta waves, and then you'll transition from the delta waves back into what looks like on an EEG, looks like you're awake. REM sleep on an EEG looks almost identical to being actually awake. And of course, in a weird way, you are awake. You're conscious, even though you're asleep, right? So REM sleep is associated with dream sleep, with dreaming, with that essential paralysis that we were talking about earlier, that when it doesn't work quite right, you wake up in sleep paralysis, or you have REM sleep behavior disorder, which really, can be really problematic. The other term we use for this essential paralysis is atonia. You also, in REM sleep, you get the rapid eye movement, which is what REM comes from, rapid eye movement sleep, REM sleep. And you get irregular breathing and heart rate that corresponds to, generally, if you wake somebody up during a dream and their heart is pounding, they'll tell you something that was exciting or frightening or arousing in that dream. So you get heart rates that correspond to whatever the content of the dreams is reported as being. And part of dreaming is you get sensory experiences, sensory responses. So you'll get things like if there's a noise made in the environment, it gets incorporated into the dream. You're picking up and processing sensory information in a way during REM sleep that you weren't doing during deep sleep. You're sleeping and you're in REM sleep. You're dreaming. Somebody rings the doorbell. You hear a bell ringing in your sleep. If you're in deep sleep, you wake up later and somebody says, "Did you hear the doorbell ringing?" And you say, "Nope, didn't hear anything at all." So, stage 1, 2, deep, and REM sleep, basic introduction. This is what I was talking about in terms of how it looks on an EEG. You can see the beta wave sleep there, the waking sleep transitioning into alpha and then into theta sleep. You see the stage 2 sleep there with the K complexes and the sleep spindles, which are the really compressed activity that you see there, and then the big jagged, looks almost like a jostling of the needle over toward the right on the stage 2 light sleep picture there. And then deep sleep, the delta wave sleep, they're high amplitude, so very tall waves and low frequency. There's not a lot of them that happen over the course. They slow way down over time. And then you see there at the bottom the representation of what you tend to see for an EEG for REM sleep, which looks very similar and actually can even look more similar than it is in the drawing there to wakefulness, to actually being awake. And what that essentially is representing is that you have a lot of activity going on in the brain and between structures in the brain because you're conscious, right? You may not be awake, but you are conscious, oddly. I already kind of spoke to some of this, but we'll go through just real quickly. One of the things you'll see on each of these stages of sleep is that it's like in this stage 1, which is also NREM 1, which is non-REM sleep 1. And the stage 1 sleep is when you transition from alpha waves into theta waves. So beta, fully awake, really erratic, really fast, alpha slowing down a little bit, theta slowing down even further. So this is the transition from alpha to theta, is what we call stage 1. We also call this light sleep. Tends to be fairly brief, about 10 minutes or so. Generally speaking, if you rouse somebody during stage 1 sleep, they will tell you that they were not asleep, but in a weird way, arguably they're not. They are, in the sense that the EEG looks different from relaxed wakefulness or full wakefulness, but they are hearing things and not that they're not seeing things, their eyes are closed, but they are aware of sounds and such in the environment. Very brief period of total sleep. And this is just interesting. This is also the period of sleep in which you experience the hypnagogic jerks, which is that sensation that sometimes people will experience where they're almost asleep and they feel like they're falling and it suddenly awakens them. As far as I'm aware, we don't really know why that happens. There's theories about, it has something to do with when we lived in the trees as lower primates and it's there to keep you from falling out of the tree. Who knows? But that hypnagogic jerk happens during this NREM 1, this really light sleep. Stage 2 sleep, or NREM 2. is when you start to get the theta waves, I'm sorry, your sleep is in theta waves, and you start to get the K complexes in the spindles, sleep spindles. This is really sleep. Like you wake up somebody from this stage of sleep, and they seem like they were asleep. They'll tell you they were asleep. You start to get behavior in the body as if you're asleep. Respiration rate and heart rate slow down a little bit. Body temperature begins to drop. This is the stage of sleep in which is most of the night for you. About 45% of sleep is in REM2 sleep. You get, like I said before, sleep spindles, which are also called sigma bands. And basically this is the brain trying to prevent you from becoming stimulated. Same thing with K complexes associated with the suppression of cortical arousal in response to stimuli. So basically what's happening is you are partly conscious, right? Because some things will wake you up. A loud enough noise, sudden dramatic change in temperature, if you fall off the bed, so you are partly conscious, minimally, but partly conscious. So there is part of your brain that's still processing, and the K complexes are partly your brain going, okay, what was that sound? All right, now I don't think that was really a threat. We're going to maintain sleep. There also is some evidence that K complexes are involved in what we call memory consolidation. Memory consolidation is taking the memories that are related to events during the day, memories of episodes during the day, things you tried to memorize, you tried to learn, those kind of things, and transferring them from what we call working memory, which is temporary storage, into permanent long-time storage that we call long-term memory. That process is memory consolidation, and sleep is absolutely integral to it. I'm going to say this again in a little bit, but if you are, and I said this, I think the first class period of the year, of the semester, if you're studying, if you're attending classes, you're trying to learn, and you are getting inadequate sleep, you are hampering memory consolidation, which basically means you might have it stored in short-term temporary memory, but it is not getting stored long-term, and you will not hold on to it long-term. So you really need to protect your sleep if you're trying to consolidate learning. Deep sleep, NREM3, what we used to call stage 3 and stage 4 sleep, characterized by the deep, slow, low frequency, high amplitude EEG waves. This is the period of sleep where it is very hard to get somebody to awaken. You have to really shake them, yell at them, that sort of thing. And they're experiencing what we call sleep inertia. It's very hard to wake them up. And when you do get them awake, they're really drowsy and maybe even disoriented. And it takes them a little while to kind of come back around. We tend to see deep sleep lasting longer over the course of the night. Total time spent in deep sleep is greater for you when you're very young, and less prevalent when you're very old. In fact, if you get really elderly, you might spend almost no time in very deep sleep. And part of this is probably because deep sleep is part of the time, one, where you're creating new memory, and two, where you are restoring and repairing body tissue. And one of the things we know about old age is that we're not as good at doing that in old age. So anything you can do to promote deep sleep as you get older is a good thing. Exercise, very, very good. Use of melatonin as a sleep aid, which I guess I'll talk about right now. Melatonin is the hormone that essentially is like the master hormone for sleep. It's the thing that your body releases when lights go out and it's time to go to bed. Your brain begins to produce and release melatonin, and that cues everything else in your body that kind of fosters sleep onset and regulates how deeply you're sleeping, how long you're sleeping, all that kind of thing. And what we know is that under stress, we produce less melatonin, and as we age, we produce less melatonin. If you are very stressed out and you're having a lot of problems sleeping, it's worth considering. The nice thing about melatonin is it's cheap. You can go buy it at the vitamin aisle in the grocery store or the drugstore. Like I said, not expensive. It's pretty safe. It doesn't tend to cause side effects. It doesn't tend to, it doesn't give you an upset stomach or anything like that, at least in the vast majority of cases. Of course, somebody out there will have upset stomach to it, but by and large, it doesn't tend to cause side effects. It doesn't tend to have a significant interaction with other medicines. It doesn't tend to heavily sedate you. A lot of sleep medicines have a problem in that when you take them, you're out. Something bad happens, your house catches on fire, and you've taken Ambien, and you're going to have problems waking up. Melatonin does not have that effect. And the nice thing is if you do wake up and you need to function, all you got to do is turn on a bright light for a little while, and the bright light actually signals the brain to clean the melatonin out of your system, and within 5 minutes or so, you're awake. So at any rate, I'm mentioning that to you because melatonin can sometimes help in the elderly with helping them spend a little more time in deep sleep, which means that it may actually help with the aging process because it puts them in a stage of sleep where they're more likely to facilitate some of the repair that needs to happen, some of the hormone changes that need to happen in order for you to feel good. We do know about deep sleep that we do know that there is some memory consolidation. Sleep in general, particularly stage 2 and REM sleep, but also deep sleep, is important to transitioning from material from working memory into permanent storage or long-term memory. Deep sleep is when you get the really weird stuff, some of the really weird stuff outside of sleep paralysis occurring. Night terrors, where the person is screaming and yelling and obviously terrified, sometimes will actually appear to be awake and you cannot get them to respond to you. You cannot get them to stop screaming. It's an awful experience if you've ever had somebody experience a night terror. Fortunately, if they experience a night terror, they don't generally remember it when they do wake up. It just freaks everybody else out around them. Also, enuresis and encopresis. Enuresis is peeing the bed, and encopresis is pooping the bed, or pooping or peeing in your sleep. Enuresis, peeing in your sleep. Encopresis, pooping in your sleep. Tend to happen in very, very deep sleep. Sleepwalking, sleep talking, somnambulism, and somniloquy. Somnambulism is sleepwalking. Somniloquy is sleep talking, also during very deep sleep. And then REM sleep, rapid eye movement sleep, looks a lot like wakefulness. Tends to occur in cycles, approximately an hour and a half to 2 hours apart. About 23% of your total sleep in adults, becoming less prevalent as you get older. When you're very, very young, you may spend most of your time in REM sleep and whatever else in deep sleep. And then, like I said before, your body, other than the atonia, the essential paralysis, your body otherwise kind of looks like it's awake. Your heart rate and your breathing vary. Your blood pressure goes up and down. And your eyes are obviously rapid eye movement. Your eyes are moving around in your sleep. I think that's about all I want to say about REM sleep. Yeah. Oh, no. Oh, yeah, of course. As we've already talked about, most dreaming, not all, but most dreaming occurs in REM sleep. This is interesting, if you inhibit REM sleep, so if we hook somebody up to an EEG and make them go to sleep, or let them go to sleep, and as they go down and they go into stage 1 sleep and stage 2 sleep and then the deep sleep, and then they start to, they're obviously still asleep, but the EEG starts to look like they're awake. Oh, look at their eyes, they're in REM sleep, let's wake them up. If we do that, you do get some impairment in the ability to learn complicated tasks. to learn things in a classroom, say to learn a complicated motor task, these kinds of things. It compromises what we call consolidation of procedural and spatial memory, which are the kinds of memory. Procedural memory is the memory of process, of doing things. Spatial memory is what it sounds like. It's the memory of, it's kind of a visual memory, I guess you could say. Those two things are obviously, those are involved in learning complex tasks. Other than that, it doesn't have any easily measurable detrimental effects. But if you take somebody and over the course of, let's say, 3 weeks, you're really mean, and you continually awaken them. Every time they start to go into REM sleep, you wake them up. And you deprive them of X number of hours of REM sleep over the course of a week, and then you stop, and the next night you let them do whatever they're going to do. What they'll do is they'll experience what we call a rebound, and whatever amount of time you kept them out of REM sleep, but they should have been in REM sleep, they will get that amount of REM sleep over that night, and maybe the next night if it was really if you really prevented them from doing the dreaming. So they get what we call REM rebound sleep, corresponding to the amount of time that they lost in the first place. So clearly, there's something about it that is important, but we have a hard time putting our finger on exactly what it is in any measurable, objective way. Anybody in clinical psychology, anybody who's doing psychotherapy, will tell you there is a clear emotional component to REM sleep, to dream sleep, and kind of intuitively will tell you that likely what is happening is that some of the emotional benefit of having dreams is part of what's leading to that REM rebound sleep. As I said before, you do have some variation in these stages over the course of the night. You'll notice here, I know this is kind of depicted oddly because it makes it look like REM sleep is shallow sleep, almost awake, but in fact it's not. It's actually a stage of deep sleep that just looks like wakefulness, so you got to ignore that part. The part that I do want to have you recognize, though, is that REM sleep tends to increase in duration the longer you're asleep. And this is largely because you can think about it like this. Deep sleep is comprised of two different parts, NREM 3 and REM, right? So deep sleep is REM sleep and non-REM sleep, non-REM deep sleep. At the beginning of the night, you spend longer periods in that non-REM 3, that deep wave, delta wave sleep. And that's largely because the first thing your body wants to do when you go to sleep is get into that deep sleep and make the repairs, make the, like let the hormones settle down, all that kind of stuff, shift the hormone production for that anabolism, for repair. As that work is done, and you don't need to spend so much, because that's going to take place over the first 2 periods really of deep sleep in the night, and then as that work becomes kind of taken care of, your brain will spend more and more time in dream sleep, working on memory consolidation, which of course is also taking place during other stages of sleep also, but REM sleep we know is involved in a certain kind of memory consolidation, especially around tasks. So that was the big thing. And the other thing I wanted you to notice is that the actual cycle tends to be about 90 minutes to 2 hours over the course of the night, 3 or 4 cycles over the course of a night. Okay, so earlier in the lecture I said we don't really know why we sleep. And that is true, but we do have some leads. So we'll talk a little bit about some of the things some of the evidence and some of the things that we think are probably factors. We do know that it clearly has a negative impact on both our psychological health and our physical health. You can't completely deprive a human being of sleep because it's not ethical, right? You know, you cause, well, if you deprive somebody, if you deprive a person of sleep for a long enough period of time, for days and days or weeks, what you'll find is they will start to hallucinate, they start to see things and hear things that are not there, and they become paranoid. So they become very disorganized, agitated, unreasonable, very, very emotionally distressed. So there's clearly an emotional component, emotional benefit to getting sleep. And again, there's some evidence, certainly in clinical practice, that REM sleep is part of this, part of the benefit. Like I said, you know, there comes a point where you can't push a person ethically beyond a certain point of sleep deprivation. Certainly when you get to the point where they're having paranoid ideation and hallucinations, you're at the point where, okay, this is no longer ethical. So we can't do it with human beings, but we can with some lab animals. And what we find is that, for example, with lab rats, you know, you're looking at a typical lifespan for a lab rat is about 2 or 3 years. You stop a lab rat from sleeping, it lives for about 3 weeks. Now, keep in mind, much shorter, much faster metabolism than a human being, much shorter lifespan than a human being. So 3 weeks for a rat is a lot longer than 3 weeks for a human. But what we're getting is a compressed picture of what happens over a long period of time if a mammal, in this case the rat, doesn't sleep. So we don't know the extent of it. I'm not familiar with, you know, I'm sure somebody somewhere in the Soviet Union or Nazi Germany probably did that research. What happens if you just don't allow somebody to sleep? I am not familiar with it, and frankly, just because of the nature of the research, don't think I would want to know. One of the things we certainly know something about is the fact that sleep is responsible for physiological recovery. I already talked earlier in the lecture about sleep's anabolic nature, the fact that it is where you begin to synthesize molecules, you begin to rebuild things after a period of catabolism, exercise, stress, this sort of thing. But it isn't clear definitively whether you get more of that kind of repair during actual sleep, especially deep sleep, than you do under periods of relaxed wakefulness or deep rest that's not asleep. There is some evidence that you get less protein synthesis, which is actually what's happening when you're rebuilding muscle tissue, say. The protein synthesis tends to diminish while you're asleep, and that's partly because you're in a fasted state. There's, especially later on, after you've fully digested everything, you know, once you've been asleep for 6 hours, there's very little left probably in your stomach. But on the other hand, so that would suggest that, okay, well, wait a minute, if protein synthesis diminishes over sleep, then maybe we're not doing the repair. On the other hand, sleep is where you get the more significant release of growth hormone, which is one of the hormones that's involved in anabolism in the body. Growth hormone is one of the hormones that is correlated with repair and restoration of the damage that's done, say, by exercise or other kinds of stress. And we know that, and one of the other things that happens during deep sleep is inflammation diminishes, and inflammation is the devil. Like, inflammation is pretty much everything bad that happens to a person, from the flu to cancer, is the result of inflammation. In what we talked earlier about depriving rats of all sleep and they die within 2 or 3 weeks, what they die of is body-wide inflammation, what we call sepsis, and it just shuts them down. Everything shuts down and they die. So while we don't exactly understand the mechanism of how we recover psychologically, or the details of how we're recovering physiologically, when we're asleep, we do know that it's necessary. And I will tell you, just on a practical level, One of the things you see if you go and you talk to high-level athletes, bodybuilders, this sort of thing, is they will they emphasize the intake of a certain kind of protein, whey isolate protein that is absorbed more slowly by the system while they're asleep. And the hypothesis is that this, because it's absorbed more slowly, it allows protein synthesis to continue throughout the evening, throughout the period of sleep, with the idea being, again, there's limited scientific support for this, but there is some practical anecdotal evidence from people using this to produce the growth of muscle tissue and the recovery from hard exercise. Again, anecdotal rather than research evidence, but anecdotal evidence is not worthless. It's just not as valuable as research evidence. One of the things we do know is that if you work somebody really, really hard, if you make them exercise really, really hard, if you subject them to significant physical stress during the day, they stay in REM3 sleep. They stay in deep sleep for longer. So we know it has that physiological recovery is a component of why we sleep. Another of the theories about the purpose of sleep is energy conservation. This can seem a little confusing on the face of it, but okay, so metabolic rate doesn't, the basic rate at which your body is using energy doesn't actually drop that significantly during sleep. It drops by 5 to 10%. About the amount of energy that you conserve by being asleep amounts roughly to the number of calories in a piece of toast. So just, you're not saving energy by sleeping, not any significant amount of energy. Interestingly, the brain, which is a significant user of calories, right? We use a lot of calories to run our brain. It uses a lot of energy. During REM sleep, and frankly, stage one and REM sleep, the brain is using essentially as much energy as it's using while you're awake. So during non-REM 3, it is using less energy, but what's happening in REM 3, in deep sleep that's not REM sleep? Well, your brain's not using the energy, but the rest of your body is. The rest of your body is doing the repair, right? Because as it's in deep sleep, that your body is repairing itself. And that's part of the reason, this is evidence. This is evidenced by the fact that when you are ill and you're having to recover physically, you sleep more, right? The other point of evidence that while we're not conserving energy, what sleep is doing is allowing us to devote energy to different projects, so to speak, in this case repair, is that as we get less efficient and capable of repairing ourselves as we age, you spend less time in deep sleep, and you spend less total time altogether asleep. So at any rate, while we don't get a significant energy savings by being asleep, it does appear that what's happening is we're diverting energy from some things onto others. For portions of the sleep, away from brain activity into basic repair, during that deep NREM 3 sleep. What was I showing you this? Oh, this is interesting. This is the diurnal pattern of body temperature. So basically, the period over the course of, or what your body temperature looks like over the course of a day. And what you'll notice here is that you get a peak around 3, 4, 5 o'clock in the afternoon in terms of body temperature. And then you get a low point in terms of body temperature about 24 hours later in the middle of the night. And the reason I bring this up is that if you are having some problems, this is one of the reasons why when we talk about sleep hygiene, things that will help you sleep, and we will talk about that when we talk about stress later in the semester. But when we talk about things that will help you sleep, one of the things we tell you is lower the temperature of your bedroom. Get it down low enough that you need blankets in order to be comfortable. Partly because that helps you get into that lower body temperature state in the middle of the night and stay asleep. You'll notice that the temperature drops by midnight. You're looking at a fairly significantly reduced body temperature, significantly different from how it is in the daytime, from the temperature during the daytime. The other thing is, if you are having problems with restful sleep, one of the ways of addressing that is monitoring your temperature. And if you are not seeing this pattern of a higher temperature around 3 or 4 o'clock in the afternoon with a reduction over the course of the evening, and if you look over on the Fahrenheit side of the diagram, the graph, on the left side you see temperature in Fahrenheit, on the right side you see it in Celsius. You'll notice we're not talking a significant variation. We're talking less than 2 degrees, a little over a degree over a 24-hour cycle, Fahrenheit, over a 24-hour cycle. But it is discernible. And if you're not getting that change in body temperature, one of the things and you're not sleeping well, one of the things you can do to promote sleep is go exercise around 3 or 4 o'clock in the afternoon, get good and sweaty. And then when you get home in the evening, take a nice shower, ideally nice hot shower, and then spend about 60 seconds under all cold water. That'll really begin to help the process of lowering. It's also good for inflammation. It reduces inflammation, helps you recover. But it'll help cool your body off, so that when you go to sleep, that body you're kind of aiding that diminishment of body temperature, which helps you stay asleep. Okay. The other thing, I've said this a couple times so far in this lecture, the other thing to keep in mind about the importance of sleep is it's absolutely imperative for what we call memory consolidation. So if you want to learn something and you're not sleeping sufficiently, you're not sleeping deeply enough, you are really complicating sleep. The way I think about this is, imagine that your brain is a workbench in a workshop, and during the day, all the stuff you're doing is you're bringing out all the things you're trying to remember and the processes. You're going from here to there. You're going to this classroom and you're trying to learn that. You're meeting somebody new and you're trying to remember their name, learning a new sport or a new instrument or something like that. As you're doing all of these things, it is as if you are taking tools and materials off the shelf and you're working on stuff in your workbench here. And over the course of the day, tools and materials accumulate on your workbench. When you go to sleep, you can imagine sleep as, the little sleep elves come out and they begin putting the tools back where they belong, putting the materials back where they belong, putting the things that you made on shelves where you can find them when the next day. This is what's happening. This is when you go to sleep. If you don't spend time in that deep sleep, what's happening is the material from working memory, from your temporary memory, is not getting stored in an organized way. So what happens is the material's working memory fills up. It's all still there. You just can't find anything, right? And you've had this experience if you've been sleep deprived over the course of a week or so, that you'll have a lot of that tip of the tongue kind of stuff, like, oh, what was that? Where did I put that? What I walk into this room, what am I doing? That kind of stuff, which is essentially your short-term memory, your working memory is full. It needs to be cleaned out by memory consolidation and stored permanently. So memory consolidation is transitioning from working memory to long-term memory, where it's actually physically changing your brain. We also know that part of working memory is attention. If you aren't consolidating, you're going to impair your attention during the daytime. Just a few more comments about learning and memory consolidation around sleep. This is kind of cool. One of the things that we know about activity in the brain while you're asleep is that it tends to correspond to the parts of the brain that you're using while you're awake. So in other words, if you're involved in a task that you're trying to learn and it's lighting up particular segments of your brain that aren't generally all lit up, and then you go to sleep that night and we watch your brain while you're sleeping, that same part of your brain will light up at periods of deep and REM sleep, deep NREM, NREM3, and REM sleep at night, which is basically evidence, we think, that what's happening is the task that was occupying that part of the brain now is being permanently stored as a memory. It's transitioning from temporary memory to long-term memory. Research also tells us unequivocally that ability to perform spatial tasks, so motor movement, complicated motor movement, that kind of thing, definitely improves, as do concentration, attention, decision making, behavior planning, higher reasoning. The data is very, very clear. Sleep deprivation impairs these things. Healthy, restorative sleep of 7 to 8 hours a night promotes these things. Very clear data. Other theories about why we sleep, for which there is not quite as clear evidence. Like I said before, there's been some evidence. There's been some hypothesizing that it protects us from predation. Certainly, that gets us out of the path. You know, if you're holed up somewhere asleep, out of the path of nighttime big predators. But on the other hand, it also makes you vulnerable. And the other thing that is evidence against this, what used to be a preferred theory about why we sleep, protection from predation, if that were the case, apex predators should never sleep. And in fact, they do. Grizzly bears sleep, lions sleep. If it was primarily to protect us from being eaten, then the animals that don't get eaten, that do all the eating, that don't get hunted, and that do all the hunting, you would expect that they wouldn't sleep, but in fact they do. Not significantly different from animals lower in that circle of life. The role of sleep in brain development. There is some evidence of the increased rate of synaptic formation during REM sleep. This is especially the case when you're really young, but even the case when you're older. But again, you know, what are we talking about? REM sleep improves the learning of spatial of things that are stored spatially, movement, kind of visual information, this sort of thing. It would make sense that and it also facilitates memory formation. It would make sense that we're making new connections in the brain while we're asleep. And then I've already spoken to this cathexis of emotion. That there is pretty solid evidence that REM sleep, certainly clinical evidence and some research evidence, that REM sleep does provide a context in which we appear to be working out some of the things that torment us emotionally, working through problematic emotions and that sort of thing. Last thing we're going to cover before we stop for this lecture is the question of how much sleep we actually need, and I've already kind of spoken to this. We do see a change over the course of a lifetime. I'm trying to think how to say this. While the need for sleep diminishes as we get older, we sometimes overestimate the extent to which it diminishes. In very old age, well, not very old age, in old age, over 65, you can sleep safely as little as 5 or 6 hours a night. Anything prior to that, you get under 6 hours a night, you are going to have problems, at least problems with attention, concentration, memory, problem solving, planning of behavior, that kind of thing, and probably physical problems. It becomes more and more and more important the younger you get. You will notice most of you are in that young adult range where the basement is 6 hours. And ideally, you're looking at as much as 9 hours in the ideal range. And I would venture that virtually nobody, almost nobody at Young Harris College is probably sleeping 9 hours a night. If your learning is not going as well as you had hoped, if you're an athlete or a musician and your performance is not going as well as you hope, and you're sleeping less than 9 hours of sleep in a night, hey, consider protecting your sleep a bit. See if you get an improvement. Just a different way of depicting this, that over the course of a general lifetime from conception to the point of death, you'll see that early on, when you're in the womb, you spend at one point nearly all of your time asleep. And then early on, the first year, you're spending 12 to 16 hours of sleep. Through childhood, definitely up through adolescence, you want to spend more than 8 hours of sleep per night. Once you get to be in your early 20s, then you're looking at 7-8 hours a night as healthy and ideal. And then, of course, as you get older, that shifts down even into 6 or 7 hours per night. But just to kind of bring this home to you, how big of a deal this is. Just a depiction of how REM sleep, non-REM sleep, and wakefulness vary as a portion of the 24-hour day over the course of a lifetime. You can see that REM sleep, dream sleep, diminishes and kind of steadies out really at around your age. Once you get into your late teens, you kind of get down to your normal amount of REM sleep that will stay fairly stable, diminishing just very, very gradually as you move into old age. And you're looking at about an hour to an hour and a half total time in REM sleep. You're also noticing that you do spend more time awake as you get older. That's normal and natural. And you're spending less total time asleep and less total time in REM sleep and less total time in non-REM sleep. Non-REM sleep diminishes less quickly and less dramatically than does REM sleep. The other thing, that's the left hand, that's the left hand graph there. The right hand graph, I'm not going to spend much time talking about it. I just thought that was interesting because it's what it's showing you in the blue is the time over a 24-hour period, the pattern of time that people tend to be asleep. So a baby is in and out of wakefulness throughout a 24-hour period. A 1-year-old spends most of his or her time asleep at night with a couple of brief periods needed during the day, one in the morning, one in the afternoon, napping. A 4-year-old spends a longer period of time asleep at night and needs approximately a nap. So you're transitioning from around 1-year-old, 2 naps a day down to 1 nap a day by the time you're about 4. The nap gradually goes away over the course of the next couple of years. By the time you're in school, you're sleeping roughly like a 10-year-old, which is about roughly 8 hours. You see that it's transitioned. You're staying up a little later and needing to sleep a little bit later. And then, of course, by the time you guys all know this, by the time you're an adolescent, you're wanting to stay up considerably later and wanting to sleep in later. There's a big argument over whether we should be moving the school day later for adolescents because of this, because this does appear to be a natural cycle. And then you get kind of a recovery of that as you move into your 30s and your middle adulthood. You tend to go to sleep a little bit earlier again and get up a little bit earlier again. And then as you get really old, like some of us, you find yourself wanting to go to sleep about 10 o'clock at night and you wake up early. Now, that depicts you as waking up around 4 o'clock in the morning. I don't wake up around 4 o'clock in the morning, but I will tell you, I used to be able to sleep until, when I was a teenager, like you guys, I could sleep until 11 o'clock easy. It's tough for me now to sleep. I'm only 50. It's tough for me to sleep past about 8 o'clock in the morning. So I'm definitely seeing this. This is a really common pattern that we do see as you age. Last couple things. This says more than a third of U.S. adults don't get enough sleep. I think that's optimistic. I would be surprised. I would estimate that it's probably closer to half. I don't remember when this survey was done, but it's been several years. It may have been as much as 10 years ago. My supposition is that we're probably looking at about 40% of the U.S. population of adults doesn't get enough sleep. Especially when you consider 7 hours is marginal. 7 hours is like, okay, that's enough. You're not going to have health problems, but and we're not necessarily looking at the quality of sleep here, because quality of sleep also does matter. Long and the short of it is, when you wake up in the morning, you should feel good. You should feel rested. You should feel within just a couple of minutes, you should feel alert, awake, and energized. One of the other things that I'll point out is evidence of this is that the graph on your left, the change in sleep patterns from 1960 to 2002. You'll look there, and in 1960, the average American was sleeping over 8.5 hours of sleep nightly. Today, we're looking at about 7 hours. Big change over a very short period in the grand scheme of things, very short period of time. And then the same thing, surveys from 1942, where well more than half of the population was getting more than 8 hours of sleep a night, and almost 3/4 of the population, more than 3/4 of the population, was sleeping 7 hours or more. Now, less than, or just a little over half gets 7 hours or more. So big change. Big change. Now, some of this may be because we're working less physical jobs generally than we were in the 1940s, 50s, and 60s. So the majority of the population has moved to non-physical labor. But as we've discussed over the course of this lecture today, sleep is not just about recovering physically, although it is about recovering physically, but it's also about recovering in terms of memory consolidation, learning, preparing to have the necessary concentration, problem solving, anticipation of consequences, planning of behavior, etc., emotional recovery, that sort of thing. So, long story short, make sure you're getting a minimum of 7 hours of sleep a night. If you aren't, you need to protect it. If you have questions about how to protect your sleep, when we come back from our midterm, I think is when we'll talk about stress and coping, and we will talk about the strategies we can use to protect our sleep when we do that lecture. All right.